Dr. Guru Raj, please.
Thank you, sir. So this is a very, very complex topic, and 5 minutes is it is going to be a just touch and go. This definition of pain aptly applies to the neuropathic pain because it's mainly both it's a psychosomatic problem. So it is pain is which is there and which is perceived. So, what is neuropathic pain? It is pain initiated or caused by primarily due to lesion or a dysfunction in the nervous system. It is not due to only injury, it can be due to any kind of dysfunction to the nervous system. So, they can present with a whole lot of these problems like numbness, tingling, burning, paresthetic, especially in orthopedic practice and in spine practice, mainly we see as a radiculopathy, and most of them they present with most of these symptoms. But then the one of the most complex neuropathic pains, which is that is sympathetic system associated pain, which happens in spinal cord injuries and mainly in association with tumors. They present with allodynia and hyperalgesias. So these are very complex pain syndromes to treat. So this is a pain mechanism. I'll not go in detail because we have short of time. So basically the pathophysiology is mainly they are non-nociceptors which get excited and then they recruit the nervous system which is not involved along with the central sensitization. So always whenever you have a neuropathic pain, there are two components. One is peripheral sensitization and again from a central sensitization. So whenever we treat, we need to treat them in a combined fashion. So that is why more than one mechanism is in action and you need polypharmacology to treat any neuropathic pain. So assessing a patient, most of the times neuropathic pains is mainly a clinical diagnosis, is substantiated by your imaging, or if at all you find something in the imaging or nerve conduction studies. But mainly it is a clinical diagnosis. That is why you need to spend a lot of time with these patients taking detailed clinical history and psychological history also, because it's mainly a psychosomatic problem. So how to differentiate? Mainly neuropathic pain is often worse at night because its psychological component is also involved. It's a anatomical pattern or a dermatomal pattern is there. It is usually along the one nerve or group of nerves shooting, radiating or a lancinating or a burning type of pain, and pain in insensate parts or pain in basically what we call it as a phantom leg. So pain where the body part is not there. So that's a typical of neuropathic pain. But then muscular pain, it's usually associated with activity. Inflammatory pain, we all know that it's worse first thing in the morning. So examining these patients, first we need to see whether there is any CNS or a peripheral nervous system lesion. And they are associated with a lot of comorbidities like cancer, diabetes, stroke patients. So we need to rule out these things very, very importantly before we start treating them. Is the pain distribution is neuroanatomically logical? If it is logical, it is easy to treat. If it is not correlating, it becomes really complex to treat these patients. And then as we have to differentiate the character of the pain because the treatment will depend on that. Is the location of the sensory dysfunction is neuroanatomically logical? Again, it's the same thing. So what are the goals when it comes to treating these patients? First, achieve the diagnosis. It makes your life very easy. Identify underlying cause of neuropathy. Identify comorbid conditions because you need to treat them along with them. Evaluate psychological factors. Evaluate functional status of the patient because you have to make the treatment tailor-made to each and every patient. And at the first visit, set goals with the patient and accordingly you tailor-made the treatment. So these are some neuropathic pain syndromes. Mainly we see these cervical plexopathies, malignant brachial plexopathies and sciatic pain. So again, the most common pain which we see in our practice, the neuropathic pain is radiculopathy. So in any pain treatment, always we should start from least invasive to most invasive. So what are the treatment? Sir, mainly non-pharmaceutical options are biofeedback, relaxation therapies, mainly these are physical therapies, and cognitive and behavioral changes are very, very important if you want to get rid of neuropathic pains because these are chronic kind of pains. So you need to do a cognitive and behavioral strategies also. Because it is multiple mechanisms are involved, you have multiple drugs available. So we'll just see them next slide. These are the FDA approved drugs. Carbamazepine is approved for trigeminal neuralgia. Duloxetine is approved for peripheral diabetic neuropathy. And gabapentin is for post-herpetic neuralgia. Lidocaine patches for, again, post-herpetic neuralgia. And pregabalin for peripheral diabetic neuropathy and radiculopathies. So, because there is a sensitization from the central nervous system, different drugs act at a different level. So, we need to diagnose it properly before using these multi-pharmacological treatments. And most commonly used drugs are gabapentin and pregabalin. They act on both peripheral and central system, so that is why they give pain relief in very early phases. And then opioids, you have to be very, very careful. You have to use fixed dose regimes and be careful about the side effects and the basically dependence. When we treat chronic pain syndromes, we need to differentiate these four things, that is physical dependence, tolerance, pseudo-addiction and addiction. I am not going in detail of these definitions, but we need to differentiate these and take care these things when you want to treat these pain syndromes. The last, interventional treatments, neuronal blockage, we are all doing root blocks or a sympathetic blocks. I'll take just 1 minute more. Neurolytic techniques like alcohol or phenol neurolysis, but there is no evidence-based basically significance for these techniques. But then the spinal cord stimulation is coming out in a big way. There are different kinds of spinal cord stimulation modalities are available. You can stimulate them peripherally, you can stimulate centrally to get rid of neuropathic pains. So in summary, neuropathic pains are usually chronic, so you need to have polypharmacy because it is both peripheral and central sensitization. You have to always balance the treatment, and new and newer agents are available which can treat the neuropathic pains. Thank you.